Hello. Uh, our first case is about a 76-year-old male with medical history of atrial fibrillation, dyslipidemia, and inflammatory bowel disease. On May, he was admitted to hospital because of an STEMI. In the transthoracic echocardiogram, he has mild dysfunction. The laboratory tests and the electrocardiogram were normal, and he's on treatment with aspirin and ticagrelor. Here you can see the coronary angiogram, in which we can see a severe and calcified lesion in the anterior descendant artery with heavy calcification around. In the right coronary artery, he has another lesion in the limit of severity. Because of that, we did a pressure wire with a negative result. So we are going to do a percutaneous revascularization of the anterior descendant artery using lithotripsy to obtain the best result in the calcified lesion, and we are going to guide the procedure with an imaging technique, which is OCT.
Okay, thank you, Clara. We are now starting the case. As you can see, I'm going to show you the setup. We are using a radial approach with a slender sheath 7 French. And we have been struggling a little bit with the access, as you can see in the angio, because of the tortuosity at the subclavian artery. And this is the angio showing the buccal there. And we could advance with a year 4 5 French catheter and a Terumo wire and a hydrophilic one. You can see here a little bit playing with the respiration of the patient. And after that, I can show you the image. This is a very good case to show the lithotripsy technique, because it's a severely calcified lesion, as you can see. Just with the angio, we are doing OCT as well. And we have 3 side branches here. Guillermo and me was discussing the best way to treat it. You can see probably the bigger one is the proximal, logically. But the disease probably is worse at the ostium of the second and the third diagonal. And also after the more critical stenosis, there is an aneurysm. And we have been also discussing of covering all the lesion, including the aneurysm, or using the landing zone, just the proximal part of the aneurysm. So we have performed the OCT. We have protected the second branch, and also struggling to get into it because of this funny angulation. And we have now one Sion extra support wire in the LAD and another wire in the second diagonal. As you can see in the OCT pullback, the catheter, the OCT catheter is also almost occlusive, but now the flow is perfect. And Daniel Tebar is now analyzing the OCT. I don't know if with this flow the images are correct or not. Danny?
Yeah. So can you hear me? Yeah. So the minimal diameter in the lesion is like 1.5 millimeters. The proximal landing zone.
You can see in the Ultron that the proximal part is in the left side of the screen. It's 3.5.
It's 3.5.
And the distal one?
The distal
to aneurysm?
Yeah. Let's see.
This is a double loop? No, it's probably, but
yeah,
it's blood, no? Probably, because of the aneurysm. And the distal part there probably is the landing.
Yeah, maybe here.
3 or?
Yeah, more or less 3.
Okay.
Can we see the first lesion, distal first lesion, please?
The calcification and...
Yes.
Yeah.
I don't know if the registry could work because of this.
You mean this?
No, the proximal part.
Ah, okay.
This you can see there. The calcification is an eccentric plaque, probably. No. Well, I don't know. I don't know. It's 230 degrees.
Yeah, 230.
Yes.
And it's very thick calcium there. You can see it. and almost circumferential at some points.
Yeah, and the diagonal branch is just here, no?
Probably is the third one or the first one because there is no wire there.
Yeah.
Okay.
So
Probably the first one because it's almost free, the ostium at some point. So we can predilate a little bit. I would predilate the diagonal firstly.
Tenemos que ver si la lesión distal era importante o no para donde aterrizamos.
I think we need to land distal to the aneurysm.
Okay.
Distal to the aneurysm.
yeah,
I think that seeing that the OCT catheter is occlusive, I think we should predilate the LAD with a small balloon. Give me, por favor, un balón de 2, semicompleto de 2.10 o 2.12, Isabel. We are going to predilate both branches, probably the LAD at the occlusive lesion, just to improve the flow a little bit, and also probably the ostium of the diagonal, the second diagonal.
El área de la distal.
And we can debate about the possibility of treating the second diagonal with a drug-eluting balloon.
Es que
2.10.
está mal lavado. Está mal lavado, yo creo.
No, es ok, es así.
Yeah, the problem of the OCT, the problem of the OCT is that probably with this aneurysm and also the occlusive lesion with the catheter, the flow and the blood is still there and not washed. It has been not washed with the contrast, and the image is not perfect. We thought that about the option of predilating a little bit before the OCT, and we tried to do from the very beginning just to not be seeing the modification. Vamos a ponerle un tercio de fenta, por favor. So we are going to predilate the LAD, and Guillermo also the diagonal.
Yes. Okay. No, es que estoy pensando que la
Espera,
la
déjame.
lesión distal también está comprometida, ¿eh? Son 2.11 de área, no sé, es bastante poco, para una área de 3.
Sí, tenemos que ir a todo.
Eso es lo que te decía, porque teníamos dudas.
No, we were discussing about la guía. Because the third diagonal is the third diagonal, not the first one, but it has also some stenosis at the ostium. And if we land the stent of the lady before this branch, it's a good option to preserve it. But the lesion that we have seen in the OCT, distal to the third diagonal, I don't know. Probably we need to treat it. So we'll check. Please test there. Contrast. Contrast, please.
Es 2 el balón,
Sí, vamos a predilatar ahí. Dale. Solamente para... We are going to predilate a little bit just to assure the crossing of the shockwave balloon. Danny, and the shockwave balloon, 3 or 3.5?
14.
Okay, this is the predilatation.
maybe 3, I think. No.
Maybe 3. Okay.
Yeah, I think, yeah. Because
Dale otra. Well, you know that this is the image with a small balloon. Okay, let's dilate the side branch. One of the shockwave and all these cases of today are being done with this technology. Probably you know it, but just to recap, it's a rapid exchange balloon connected to electric energy, the generator that is there. I don't know if you can see with the cameras.
Estamos con la diagonal.
Con el mismo, sí. El mismo balón para la diagonal. And this electric energy is transmitted through a connection cable to the shockwave balloon. That is a semi-compliant balloon. We have 4 lengths from 2.5 to 4, two diameters, and all of them 12 millimeters in length. And the balloon has 2 emitters that transform this electrical energy given by the generator in sonic pressures, in acoustic waves that are produced inside the balloon in the mixture of contrast and saline and transmitted to the lesion. And these waves pass through the soft tissue and modify the calcified plaque, not only the intima and superficial plaque, but also the este ya inflado. Ya voy. Ahí está. Venga, vamos suave, ¿vale? Also the thick and medial calcified plaques.
12.
Okay, I think it's enough. And one advantage of this plaque modification technique is that, as you can see, you can use it through a conventional 0.14 wire. And it doesn't need a specific wire. And you can also use it by a 6 French guiding catheter and protect all the side branches you want. So this case illustrates very well some of the advantages of this technology.
La verdad es que es abajo un 3 y arriba un 3,5.
Okay, let's check again the size of the shockwave balloon, because we need 1 to the vessel.
I think let's see the proximal vessel to the lesion is like 3.0. So I think yes.
Okay, ¿nos dais el shockwave de 3?
Ya, pero no sé si para los siguientes 3,5, ¿eh? Para
Este es 3.
Ya, bueno, pero que a lo mejor con el 3 llegamos. Vamos a usar 2, ¿no? So you have to use a balloon sized 1:1 to the vessel diameter, and intracoronary imaging is a key point of the procedure to assure that.
Look, the proximal to the first lesion is to 3. I think is 3 the balloon. Yeah, 3 third.
Okay. And the preparation of the balloon is a mix of saline and contrast 50-50. And as you can see, Patri is going to remove the air very consciously, because the air is going to hamper the transmission of the sonic waves to the vessel. So it's very important, not only for the efficacy, but also for the safety, because if the balloon breaks, probably having air there is not good. So we are going to try to advance the shockwave balloon 3.0 after this slight predilatation with a 2.0. Tenemos la funda. The shockwave catheter, the balloon, should be connected to a connection cable that is also connected to the generator. Saturación no la veo, Pilar. ¿Estáis a ver lo que está dormido? This plastic cover of the shockwave is one important thing. It seems easy, but it is not so easy. And the next generation, the C2 Plus balloon, apart from the most important advance that it has 120 pulses, not only 80 like this one, it has a specific plastic cover to for the connection. This one is the C2 shockwave balloon, and we have 8 cycles of 10 pulses each one, so 80 cycles, 80 pulses. We're going to connect. I don't know if the camera can see it. We see here in the console 80 pulses and a yellow light And when the balloon is there in the not now, when the balloon is there in the lesion, we're going to press this yellow signal and it will turn to green. Okay. Another important part is to hold both together the deflator and the not to kink it. Dame eso, dámelo. Just like that, because if not, this part could be kinked. Ok. ¿Lo pillas, Patri, esto? Venga.
Cambiaste las líneas, ¿no?
Sí, no lo sé. Esto, Isabel, me lo tienes que mover un poco. Y dejarme ver la pantalla.
Voy a ver aquí abajo la blue.
Es que no veo nada. Esta es la diagonal.
Ok.
We are doing firstly this part. Another option would have been to dilate without agglutinin firstly the diagonal. Let's see how it works. Ok, tengo. ¿Ya tú eso, Guille?
Tú cógete la mando esto y yo me cojo esto.
Cuidado que me está... Let's check the first angio just to... So we are going to predilate from the aneurysm to proximal. Okay. If the balloon crosses, let's check. Okay, the balloon has crossed easily, as you have seen. It has two radiopaque markers at the proximal and distal ends of the balloon. Test, please, Patty. It's almost occlusive, I think, there. So we have to connect the yellow light. Dale. Vale. Okay, so we are going to inflate to 4 atmospheres. And then, when the balloon is inflated, 4, I'm going to press this button to apply the pulses. You can see a countdown in the console in the generator. And after that, 10, okay, we up to 6 atmospheres and maintain inflated until a sound is heard. Okay, down. You can see in the hemodynamics that the patient is doing some extra beats.
In the CG.
In the CG. Okay, let's do another run. 4.
4.
And applying the second cycle of 10 pulses. The blood pressure is okay. 6.
Yes, you can see the EKG captures.
Yeah, these are the shock beats. The energy, the electrical energy of the shock wave is down. Is captured by the left ventricle, and sometimes you see some slight decreasing of the blood pressure, but always well tolerated, or almost always. But here, in this case, because of the limitation of flow, probably the patient has done some extra beats. We have done 20 pulses, probably another run here.
Okay.
The expansion is not bad, but I think we can do another one. 4. There is no consensus about that, to the best of my knowledge, but the recommendation is to administer at least 20 pulses in each lesion. You can see there the extra beats, the capture, 6. I think the expansion is not bad. Down. Let's check in the spider view where we are, because we are near the ostium of the lady. Test, please. Ok. Un poco más proximal, ¿os parece?
Sí. Yes.
La lesión distal no la queremos, esa que íbamos a aterrizar más distal.
Sí, pero no parece tan calcificada, ¿no?
Ahí hay calcio, ¿eh? Si tenemos pulsos de sobra.
Vale, entonces le damos primero la proximal e intentamos pasar distal.
Sí, perfecto.
Venga. I'm going to retrieve a little bit the shockwave balloon. Just here, test please. Probably there.
Yeah.
Okay. Ahora te lo digo. 4 atmospheres is the same sequence all the time.
4.
4, and I press the button again, and the pulses have been administered. You can see the ECG. Some of them are captured, some are not. The pressure is okay. Okay, 6 atmospheres.
6.
Expansion is quite good here. Down. I think we can do another cycle here. And then Guillermo was saying to administer as well at the distal lesion.
4.
4. 6. You can see the calcium, the bulky calcium outside the vessel, but the expansion of the balloon is quite good. I'm going to again to the cranial view, just to trying to advance the inflated balloon. Sometimes it's not easy, and we decided to predilate firstly the more proximal lesions. Let's see if we can cross. You see that even with the inflated balloon, it's almost crossing there. Almost.
Yes, the balloon is.
The balloon is stuck there
inflated.
because we have inflated it. I think I have advanced a little bit more.
Yeah.
Let's do a test, please, Patrick. I think we are there.
We have 30 pulls.
Let's check because we haven't protected this third diagonal, and we are there. We are now here, just in the diagonal. You want to predilate here?
Yeah.
A test a little bit. Sorry.
Yeah.
If I can advance 1 millimeter more. Okay, I think we are there. So 4. Okay, I'm applying the pulses. The expansion is quite good there. Okay, 10 pulses, 6. As you can see, we don't want to inflate to high atmospheres the shockwave balloon. It's just to oppose the balloon to the calcified plaque and down, and be sure that the sonic waves are doing their job. Okay, I have advanced a little bit more, as you can see.
Yeah.
4. Pulses. Expansion is quite good here. Let's see if the third diagonal has behaved well. 6.
We hope.
I think it's enough, no? After this. Down. Okay. Retrieve the balloon. Okay. Let's check with a test. Test, please.
Yeah.
The flow is conserved. The diagonal is there. So be careful. This is the thing. If you retrieve it, you can kink the balloon. Okay, I'm retrieving the shockwave balloon. And now we have to decide what to do, to perform OCT, to post-dilate with a non-compliant balloon, or to treat the diagonal first. Let's do a cine probably. Contrast, please. And with the cine we can decide. Okay, the catheter is a little bit out.
We can put a wire in the third diagonal, and after to use an 8-inch balloon. No?
Okay, let's do a cine here. The first diagonal is a little bit different in the ostium. but the flow is okay.
Yeah.
You see the calcium there is amazing at both sides of the vessel. We can do it. We can, and why don't we pre-treat with a drug eluting balloon the diagonal we have, and then protect the third one. 2-0. Danos el balón de fármaco de 2. We're going to pre-treat because we are trying to avoid a double stent technique because of the lack of space there, and to prevent putting a lot of metal in a small space, because probably the risk of thrombosis and restenosis is higher.
Solo hay un balón de 2.
220.
Solo hay uno.
So we are going to dilate with a drug-eluting balloon, a magic touch. That is a sirolimus eluting balloon, the second diagonal. That was the one we protected and predilated. And after that, we can try to cross a wire towards the third diagonal. Probably it is not going to be easy. And then post-dilate with a non-compliant balloon. 3-0, Danny?
Yeah, 3-0. Definitely.
Probably 3-0 at the distal part and 3-5 in the proximal.
Yeah, 3-5 here in the more proximal lesion.
2000 de parina. Isabel is asking me about the heparin. As we are going through the radial approach, after the 31st minutes, we administer a little bit more of heparin, and if we continue after 1 hour, we check with the ACT. This is a custom we have for the CTO procedures, and it's a very good issue, I think, a very good thing. Okay, you have the... I don't know if this is the diagonal, sorry.
No. Pido que eso.
Sí. Ok, píllala, por favor.
So in the OCT now we are seeing the first diagonal, and as you can see, there is a lesion in the ostium.
Yes.
So
we're going to protect the three diagonals.
The third diagonal.
yeah,
Sequence.
Okay, just the ostium, no? So I'm going to enter here. Patrick, por favor, un test.
¿Cuál era el balón? Aquí,
6
no,
atmospheres.
más, eso es.
So just here is a 2-0 balloon. Dale, 6. And you need to inflate it. The nominal pressure is 6. Okay, and just maintain 1 minute. You have there the chronometer. Isabel, assume blue. We're going to use a third wire, and I repeat it again. This is another advantage of the shockwave and the lithotripsy technique. The calcification is huge there in the OCT. And now that this drug-eluting balloon approach is in some fashion is down. It's moving from the small vessels and side branches and restenosis to all the settings, and we are using more and more it. You have to be comfortable with these dissections that are not flow limiting, but for sure the immediate result is more beautiful with a stent, but the possibility of not leaving anything there in the vessel is very good. Okay, let's retrieve it. The blood pressure is okay, everything is okay. Let's do a test, please. Okay, the flow is there. So let's try to advance the Sion wire, the Sion blue, to the third diagonal.
Y vamos a un test de momento, ¿no? Un test no compliante primero y ya si acaso abajo. un 3 no compliante, ¿no? 3.0 no compliance. 3.0 no compliance.
So this is the diagonal.
15 yo creo que está bien, sí.
We selected the EVU 7 French 3.5 and probably 4.0 have been a little bit better because we have seen these difficulties. Okay, let's me talk. As you can see, this diagonal, the third one, have a very acute angulation there.
Yeah.
And it's also at the point of the aneurysm, it's not going to be easy to cross it. Test, please.
You see here in the OCT, the ostium of the third diagonal branch that is very angulated. And harder to cross maybe with the wire than the first one.
Test, please. Yes, the aneurysm doesn't have
Yeah.
anything because it's quite big. I'm going to change the curve. And if not, we can use a dual lumen microcatheter or just leave it without protection because we have dilated with a shockwave balloon and this diagonal is the same now. Probably the aneurysm hampers the crossing to the side branch, but also protect it to be occluded. So I think it's reasonable to try to cross it 5 minutes or so, and then if not, we can continue with the post dilatation. What are you doing? This almost there, as you can see. But the angulation is funny test. ¿Me dais una Sion Black, por favor? Test, por favor. I'm going to try with I'm almost there, but the lesion is quite severe there. And it's difficult to... Okay, let's retrieve this one and give me the cyan black. Doing the same curve probably, or similar one. And if not, we can debate the possibility of a dual lumen or just leave this branch.
I think it's... Can we leave this branch, no?
Yes, because its behavior with the pre-dilatation, with the shock wave. I don't know, you never know. I think it's reasonable to spend a little time to trying to protect it. Pero Patrick, no toques.
Si no traer un...
Está traído un Find Duo ahí.
Sí, hombre, es verdad que es interesante la diagonal.
Test, please. Angulation is...
Yeah.
It's possible to use one venture
Test,
microcatheter
test.
or... I don't know if it's necessary.
Test. I am almost there, but as you can see, it's the aneurysm difficulty a little bit
Sí, sí,
Dame el Find Duo, por favor, que está ahí.
mejor podemos cambiar de proyección, ¿no? Porque a lo mejor hay una...
Cambiar de proyección, sí,
Sí,
puede ser.
no sé si nos está dando una proyección en...
Mm.
No sé si más...
Yes, another option is to change the projection a little bit. We can try the right cranial. Test, please. Nice. The angulation is terrible.
Yeah.
And also the aneurysm, because only with angulation probably you can manage reshaping the wire. All right, test, please.
Ahí
Is there. Okay, let's use the Find Duo. I'm going to retrieve this wire. Okay, let's check which wire it was. This is the diagonal, right? So, dame una gasa mojada, por favor. ¿Qué tiempo llevamos? ¿Qué hora es? 42. Venga,
¿Qué
continúa.
hora es, Dani?
42. Lo quiero en la de la DEA. No, o sea que me lo des por aquí. Dame el micro primero, el micro. So this is a dual lumen microcatheter. You can advance it as a rapid change through the wire we have in the LED, and then trying to advance a second wire through the distal port. ¿Tienes? Okay, got it. Is there? I can see the second. Okay, there. Okay, test, por favor. I don't know if using the dual lumen, the pre-shape curve is different, but it's another option. And if not, I think after 5 minutes we can continue with the predilatation.
Yeah, I think so.
Just to be on time as well. Okay. No. Está saliendo muy paralelo.
Será muy paralela. Sí.
Test, por favor.
Igual que hay que ponerlo más proximal, ¿no?
Sí. You can see both markers of the dual lumen. and the wire is exiting just in the proximal marker. It doesn't help me much more here. But we need a and I don't want to do a knuckle there. Vamos a sacar esta guía, voy a hacer un poco más de J, porfa, una diferente. Pon aquí mi introductor. I'm going to change the shape of the distal tip of the wire because it was done before the dual lumen microcatheter, and this I think is the last chance to cross to this diagonal that is remain in mind. Is that the third diagonal is not a very big one, but we are trying not to lose it. Thank you. Test, please. Almost there. Test is there, but I don't know if the wire can advance. Probably we need a wire with a little bit more power, and I don't know if it's reasonable to upgrade in this for this small diagonal. I'm almost there. Test. And see, probably with a fielder or a pilot or a Gladius you can cross it. It's moving a little bit. Okay, I think we can move forward. Test, please. It's almost there. And the wire cannot cross. What do you think, Guillermo?
Or we use angulate microcatheter or move forward. I think the second option is best.
Okay. Let's move. So we have the non-compliant balloon 3.0.
Yeah.
We need another balloon first for doing the trapping. ¿Usamos un 2,5 normal o el trapit?
No, aquí vale el 2,5.
Lo tenemos. Dame un 2,5 17 de Mozek.
¿Pero para qué lo quieres?
Para sacar el microcatéter.
¿Es monorail?
No. Yo puedo sacar...
Es
Bueno,
monorail,
sí, es verdad, es verdad. Nada, no lo abras, es verdad que esta pasamos. Vale, ok. Saca esta guía, por favor. Tienes razón. We're going to retrieve the dual lumen microcatheter. If you have a wire you want to preserve inside, you need to do trapping. But now, as we haven't crossed through the side port, we are retrieving it as a rapid exchange balloon. And we are going to continue the procedure, dilating with an NC balloon. Let's check which wire is what. This is the one of the LED. This is the one of the LED, okay. So you mark this one with the torque and continue with the NC balloon dilatation. Probably the other projection is better. The first one we did.
Yeah.
Okay, continue.
Sí.
Sí. It's a non-compliant balloon 3 by 15. We are not doing OCT before after the lithotripsy, just to save contrast and time. And probably we will check the final result of the stent. And also we see something strange with this dilatation.
So as you can see, this is the distal vessel, nearly 3.0.
This.
And this is the first dilatation
There.
we are doing.
You have seen the 3O balloon has crossed easily. Okay, this is the distal portion.
18.
Okay, down. Hopefully the third diagonal maintains open. Up.
Here is the ostium of the third diagonal.
Expansion is quite good, maintaining inflated. I'm going to see in both projections. The expansion is quite good, down. It's important to see this expansion in orthogonal projections. Sometimes you have some surprises. Up. Quite good here. Maintain it, please. I think very good. I think it was the most tight lesion, the tightest lesion here. Probably.
Yeah. There's
another more up. Now, this is another portion.
20.
Very well expanded. Also here, okay, down. And problem is the portion of the first diagonal that is not protected. But I think the ostium was almost free. Give me a test, please. Wait a minute, just to be sure not entering in the left main. Test, please. Probably test. A little bit more distal. Test. Okay, there. Okay, up. Look at the small space we have between the circ and the first diagonal.
Yeah.
Because the Y is in the second one. Okay. Very good expansion here. And also here. Okay, down. Let's check how was everything. Also the side branches. And decide the stenting, no?
Yeah. Is the landing zone 3.3, no?
Test, please.
Yeah, the distal landing zone is 3.0.
I think all the side branches are there.
And the long?
And the long, do you remember?
The length.
Okay.
The length.
Yeah, the length of the stent is.
You think we can go with only one stent, or we need to overlap?
I think it's possible only one, no? Because
3.0 and then put the proximal.
48 millimeters, more or less.
Do you think it's going to cross, or we are going to struggle?
I think it's possible to cross.
Yeah, maybe with 348.
We can try at 348. I don't know if it is going to cross.
Well,
we can try.
I think we can try. Yeah.
Danos un 3 por 48.
¿Por 48 por 38?
Si te dan ni 48.
48, 38 parece.
48, mira el objetivo.
Estas son las medidas. ¿Un science? Sí, hay science. Science.
We're going to use trying to use a very long stand. 3 by 48, according to the measurements of the OCT. Yeah, probably 48 is a good option. We have some space distal to this aneurysm to land if the lesion is a little bit shorter. But yeah, we want to land distally to this diagonal, third diagonal.
Yeah, yeah.
Probably 38 is not enough. Okay. Venga. Vale, vale. ¿Ves? Vengo yo. Okay. That's one thing. And maybe the first diagonal is a little bit. Let's continue. Let's see.
Come on, come on.
Okay, I'm there. I think I am there. Probably I have to retrieve a little bit even.
Yeah.
I'm going to cross if I can more distally. But I am there. I am in the second diagonal, so
Yeah.
test please here. Distally, I think is a good position, and we
Yeah.
have to manage the proximal part. Let's see. Test please. Have to advance a little bit more.
Yeah. A little more.
The guiding catheter is not helping. We have to be sure that we don't get into the left main. This wire, and also the guiding. Test, please. No.
Si no, pues ponemos un extensor y ya está. Suéltame aquí, que a ver si le sujeto un poco el...
No, don't worry, don't worry. Quita. No, even all the time I advance the guiding, the stand is going back. Let's see there, test please. No, I need something else to cross. Okay, I crossed.
Yeah. You
I
did.
crossed. I don't know where I am. Test please.
Yeah. Oh, no.
Let's do a cine here. Cine.
Yes, perfect.
I think it's perfect there.
Yeah, it's perfect.
You agree? Okay. Because if I retrieve a little bit, probably I get into the circ, so I think it's the point.
I think it's okay, yes.
Okay, up. Aguanta. Expansion here is quite good. And look here, the expansion. Down.
That's pretty good.
And this is not a usual pot, probably because we have no space at the proximal part between the first and second diagonal and the circ, but probably we need to post-dilate the proximal part of the stent. Right?
Yeah.
Let's see if everything is okay. Refill.
Yeah.
Test, please. The third diagonal is there. So give us a 3.5 non-compliant balloon.
Look at this. This is the proximal vessel, and the diameter is no more than 3.
Let's see. The lumen, you mean?
No, but no. More
proximal, Dani.
More proximal
This
is.
is the circ. Okay.
Ahí.
Yeah. So
Advance and there.
There is 3.
But we can
Three.
use the no
Maybe
3.
3.
Now,
With
the lumen is
The-
3.25.
25. Yeah.
Probably we can go to 3.5.
Okay, I think so, I think so. O si no podemos chequear luego.
No, if you measure in the EL, you need to go 1 or even go lower with the sizing. But if you are measuring the lumen, you need to use a little bit bigger balloon.
3.5 no compliante. Es hacer un cine, ¿no? A ver si están todas las diagonales y tal.
Están, las he visto. El más corto, ¿no? Bueno, dame 12, si no es un pot. No, we were thinking about the length of the non-compliant balloon. We usually use the shorter one to do pot proximally to the side branch, but this is a different bifurcation because we don't have enough space between the circ and the first diagonal, so we need to optimize the proximal part of the stem. We're going to use a 3.5 by 12. And if everything goes well, probably after that we can do an OCT and finish. If we have 5 minutes more, I think we... Okay. Nominal o un poquito más. Un poco, ¿no?
Que es 12 nominal, Patri, este.
Sí, son todos, ¿no? Ok. Probably from here
Okay.
is the proximal. Okay, let's go.
12.
Perfect. Down. I'm going to use the spider view for the proximal part. $12.
Okay.
Okay, down. And then just the proximal part of the stem. Probably more caudal is better. Test, Patri. I think that's... I'm there, okay? Dale, 18 si quieres. Perfect.
18.
Perfect. Down. Blood pressure is okay. CG is okay. Let's retrieve the balloon. Test, please. All diagonals are there. OCT, ¿vale? No. Ya estamos para el new run, ¿no? Okay. ¿Pilla? Tengo yo. So it's interesting to use OCT after the plug modification technique to know if the result is fine. But if you want to save some contrast and you see a very good expansion in two orthogonal projections after NC balloons, after lithotripsy, probably you can skip this step and go to the distal, to the final OCT, if we can cross it. Let's check if we can cross it. You know, that is a usual thing with OCT that after the first or second use, the catheter is not so pushable, but slowly you can open the Y connector, and I think I'm there. Okay.
Yeah, that's enough.
Okay. Let's check if the guiding catheter is inside the vessel. Ponme izquierda, Patrick, un segundo y dame un test. Okay, I think I'm there. Let's work it here. Okay. Se ve regular, ¿no?
¿O está roto?
No sé, igual está rota. Bueno, comenzamos secuencia, ¿vale? ¿Preparados? ¿Comenzamos?
Uy, uy, uy.
La imagen no se ha podido calibrar. ¿Aceptar?
Yeah, there is.
I don't know if there is some issue with the catheter.
Okay, the animation is good. So, go.
Inyecta.
Yeah.
No, something is wrong with the catheter.
Yeah.
Let's stop it.
I think it's broken.
Actually, it's now retiring.
Yeah,
No,
I'm going to retrieve it.
I think
Yeah.
it's broken.
I think the lens is broken because of this struggling in the advancing, and probably we need to open another one or trust in the angio.
Yes,
Let's check with the last cine we did.
we believe the angio.
I think the result is quite good. Obviously, the more proximal, the mid part of the stent is the worst part, but the area is quite good. The three side branches are patent, and I think it's a nice result. What do you think? We can do another projection.
It's a very good result, no? Yes, orthogonal projection, but
It'll be better if we have had this OCT, but probably to use another one just to check it is not so reasonable after this angiographic result and the feeling of the expansion of the balloons and stents. Fine?
Yeah. It's pretty good.
I think it's pretty good. So I think we're going to finish here and retrieve all the material. Thank you for your attention. We haven't had any questions from the audience today. I think we have explained everything. I don't know if is there any question.
We don't have any questions. No,
No questions. Okay.
no questions.
Everything is clear about lithotripsy. So we're going to finish the connection and see you for the second case. Bye bye.
Bye bye.